So as you know, the oroesophageal barrier is able to start digestion to allow the passage of food bolus into the stomach and prevents the reflux of acid and gastric juice. At the same time, is able to act as a barrier between external and internal environment. It is able to inhibit the passage to potential dangerous substances. Here we can see the first line of defense, the anti-reflux mechanism, represented mainly by the diaphragm and the lower esophageal sphincter. The noxious agents are represented mainly by the refluxate, so HCl and pepsin, bile, salts, and pancreatic enzymes, and at the same time, microorganisms and food antigens. So in physiological situation, we have a continuous passage of food through the esophagus and through the oral esophageal mucosa. But in a healthy barrier, we don't have any damage to the luminal surface. This is allowed by two mechanisms, the luminal acid clearance and an esophageal-specific epithelial resistance. The luminal acid clearance is represented by the swallow-initiated peristalsis, the gravity, and the saliva with its main component, the bicarbonate. However, these three elements are time-dependent, since the gravity is able to act only during the upright posture, but not during the sleep hours. For this reason, we have the esophageal specific epithelial resistance that is composed by the mucous layer, an epithelium, an acid transport mechanism, a continuous blood flow, and finally, regeneration processes mediated by cytokine. All these elements compose the well-known tissue resistance of the esophageal epithelial barrier. The mucous layer is composed for the 90–95% of water, for the 5–10% of mucin, and then there are other specific elements of the esophagus that are the bicarbonate, the prostaglandin A2, the AGF, and the TGF-alpha. Mucus production is increased and stimulated by the activation of the receptor 5-HTR4, the receptor of serotonin, but also by acid and pepsin, especially when there is a high concentration of these noxious agents. This slide was already proposed by Professor Gasbarini, just to show you that in the oral cavity, we have two types of gel, two types of mucins, a gel-forming mucins represented by MUC5B, MUC7, and MUC19, and then a cell surface mucin, MUC1, 4, and 16. At the same time, we have some substances that are antimicrobials that can be non-specific, such as the defensin, but also specific, such as the EGA, the EGG, and the NGM. And this is very important for one of the most important and crucial events that happen in the oral cavity, that is the oral tolerance. In the esophagus, we have most of the mucins coming from the oral cavity, but we have also some specific mucins, such as the mucin 5B, but we have then mucin 2, and mucin 5B and 2 are representing the gel-forming mucins, and while mucin 1 and mucin 4 represented the transmembrane mucins that have the characteristics to have the N-terminal subunit containing glycosylated tandem repeats that contributes to the mucous gel, but then at the same time on the other face, a C-terminal transmembrane subunits that function as a receptor for cell signaling. Mucins and mucins modulation has been proposed in many diseases that affect the esophagus. Mucin, in fact, can modulate the epithelial barrier, and we know that during gastroesophageal reflux disease, we have an increased production of MUC5AC, MUC6, MUC6, along with MUC2. These mucins coming and the mucins coming from the oral cavity can be an efficient tool to contrast the noxious agents that comes from the stomach. However, if this tool is not efficacious, we have a progression of the gastric esophageal reflux disease toward metaplasia and towards Barrett esophagus. Also in this case, Barrett esophagus is able to cope with noxious agents, but if this tool and this modification is, again, not able to contract the noxious agents, we have a progression to adenocarcinoma. In this progression, it has been demonstrated that there is a decrease of MUC5AC and MUC6 and an increase of MUC1. These are poor prognostic factors, and you can imagine how important is this for our clinical practice, because this decrease can be, in our future clinical activity, an element that we can exert to diagnose this progression. Then we have the epithelium. In the oral cavity, we have a keratinized epithelium, but also a non-keratinized. In the keratinized epithelium, the sebaceous glands, the fatty acids, and the phospholipids with the glucosylceramides are the main components. The sebaceous glands are able to secrete the antimicrobial fatty acids. The most important are the lauric acid and the sapienic acid that can modulate and shape the commensal flora in the oral cavity. At the same time, one of the best one important point in this slide is that in the oral epithelium, the morphological geometry of the fatty acids, the phospholipids, and the glucoceramides is different compared to the skin. And this allows the oral epithelium to have a greater permeability compared to the skin. One important point, as I was saying before, is the oral tolerance. In the oral cavity happens many of the most important mechanisms besides and below the tolerance, the systemic tolerance against self-antigen that continuously comes into contact with the oral cavity. One of the most important factors is the TGF-beta that cooperates with the Treg cells, and you can understand how it's important to modulate and the correlation that there is between the microbiota and this mechanism. In the esophagus, we have a multi-layered, non-keratinized, stratified squamous epithelium with 3 layers, several layers of stratum granulosum that is mainly involved in the permeability and in modulating the esophageal barrier, a stratum spinosum that is mainly involved in the passage of ions, and a stratum germinativum basalis that is involved in the regeneration process. So beside the cell membrane, we have also apical junction complexes that cooperates in maintaining this barrier. Between these, we have the tight junction with the occludin 1 and 4, the adherens junction with E-cadherin, and the desmosome, the desmogleins, and the desmocollins. Tight junction and adherens junction have the characteristic of enroll and circle all the cell membrane, and they can construct a seal between the cell membrane and the intercellular space. On the other side, desmosome can create only a spot, a wild spot between the cells, but can construct a strictly connection between the cells and create a single and unique layer of cells. Also, tight junction, adherens junction, and desmosomes have been implicated in esophageal disease. For example, in gastric erosive reflux disease, gastric esophageal reflux disease, we know that we have an increased permeability, and in these slides, the increased permeability is represented directly by the transmembrane resistance and indirectly by the concentration of FITC. In GERD, we know that there is an increased permeability, and this can be also in part or completely explained by the E-cadherin modulation. In fact, we know that in GERD patients, we have a cleavated form of E-cadherin that is cleavated by a metalloproteinase that is activated during and in response to the acid reflux. As you can see in this immunofluorescence, we see in normal patients and in GERD patients that we have a basal activity of ADAM10, that is the metalloproteinase implicated in this phenomenon. In normal people, the ADAM10 is mainly basolateral, while in GERD people is also apical. And this concentration of ADAM10 in the luminal phase goes in a reciprocal way with the concentration of icadherin that in normal situation is luminal, while in pathological situation is concentrated in the basal layer but not in the luminal layer. So in GERD, we have noxious agents that can weaken this tight junction and this connection between cells and provoke a damaged gut esophageal barrier with the passage of noxious agents to the lamina propria. Then we have the mechanism of acid transporter that can be divided in intracytoplasmatic mechanism and transmembrane mechanism. In the cytoplasm, we can see that we have a buffer of protein, bicarbonate, and phosphate that can neutralize the excess of hydrogen into the cell. We have another important target also for our therapies, that is the carbon anhydrases that can produce bicarbonate. In the basolateral part of the cells, then, we have two kinds of pumps. The cell alkalinizer that can increase the pH when this is low, and a cell acidifier that can work in an opposite way. Of course, all this activity can be exerted only when there is a continuous blood flow, an efficient blood flow that can deliver oxygen and nutrients to the mucosa, but also can act as a scavenger for all the debris and all the ions that come out from the luminal phase. Finally, we have a regeneration processes that is mediated by cytokine. In the regeneration processes, we can distinguish two mechanisms. A cell restitution mechanism that is the fastest, and in this mechanism, we have the viable adjacent cells that migrate to the necrotic area, and this is the fastest one. And at the same time, we have the slowest process that takes days up to weeks. That is the cell regeneration mechanism that is due to the basal line, to the stratum germinativum. And this process implies mitosis and replication of DNA. All these processes are mediated by growth factors such as the EGF, the TGF, the hepatocyte growth factor, and the keratinocyte growth factor. So let me speculate on this process. What happened in the intestine, we can say that in the esophagus, when we have an ulcer and a damage on the epithelium, there is the secretion of substances called alarmin that can recruit the inflammatory cells, and between these alarmin we can think to IL-1, IL-18, IL-33, IL-36. This alarmin can recruit a Th1 immune response or a Th2 immune response, so causing inflammation. But at the same time, the same cytokine in a different phase of the inflammation can produce and promote an epithelial restitution and repair, and on the other phase, also dysplasia and cancer. But the microbiota. So for several years, esophageal microbiota, the esophagus was considered sterile, since the esophagus is not retained to retain food. Culture-based studies showed that the main actor in the esophageal microbiota is Streptococcus viridans. Then, with the culture-independent methods, we saw that there is a big similarity with the oropharynx microbiota, that the large majority belong to known families and are cultivable, that there is a predomination on transient bacteria, and a very interesting data is that certain highly abundant oral bacteria, such as the spirochetes, are not present. We don't know why, maybe because there is a selective passage, or maybe because there is a selective retention. So Pei his collaborators studied the biopsy and the microbiota coming from the biopsy of the lower esophagus and showed that the main genera present in this esophagus were the Streptococcus, the Veillonella, and the Prevotella. These data were further confirmed by many recent studies. However, many issues are still open. So we don't know if the microbiota has a barrier function also in an esophageal barrier, such as like what happened in the gut, in the colonic barrier. We don't know which role has the microbiota modulation in oral tolerance. We know that several pathogenic mechanisms, such as microorganisms, such as Candida albicans, Cryptococcus, and herpes virus, are able to cause an infection. Is this due to a microbiota imbalance, such as like what happened in the intestine with the infectious related diarrhea? Are the conditions of the oral cavity able to modulate esophageal microbiota? Moreover, what is the effect of long-term PPI treatment on microbiota? And finally, of course, what is the pathogenic role of microbiota in esophageal diseases? So finally, we can say that the oroesophageal barrier is an integrated network with physiological and anatomical mechanisms that can cooperate together and can be also a therapeutical target in order to promote and maintain a physiological homeostasis and, of course, the gut health. Thank you.